Thank you again for joining us today, and I greatly appreciate everyone taking their time to come here and listen to our today's series. We have some housekeeping rules. A reminder again that we will be recording this session. If you do not consent to be recorded, please drop off the meeting at this time. Thank you for your patience and understanding and cooperation. So today, our first presenter will be Ms. Aimee Rachel. Aimee Rachel is a trauma-informed care clinical coordinator for the Texas Association of Community Health Centers. In that role, Ms. Rachel is responsible for the coordination of trauma-informed care project, curriculum development, and providing training and consultation to health centers on the implementation of trauma-informed care. She provides expertise in data collection and aggregation, particularly to ensure health centers are empowered with qualitative and quantitative information about their trauma-informed transformation to ultimately improve outcomes for patients and staff. Prior to joining TACHC, Aimee has worked to create a system of change to ensure the quality of service, particularly for patients living with HIV, as the Senior Ryan White Supervisor for a federally qualified center. Aimee brings a strong commitment to family, faith, and community service and has received numerous awards for her contributions, including those focused on innovations, social work practice, and inclusivity. Aimee's graduated with her Bachelor of Social Work from Texas Oklahoma Women's University in Texas, has her master's degree in social work with a focus on trauma-informed care and systems transformation from the University of Buffalo, New York. She is currently enrolled at the Doctorate of Education and Leadership and Organizational Change at Baylor University, and she currently lives in Texas with her family. So at this time, we'll turn our attention to Ms. Aimee Rachel, and thank you for joining us again. Ms. Aimee, the floor is yours.
All right, thank you. Go ahead and share my screen here. Thank you for inviting me to be here and to be able to talk about what trauma-informed care in a dental practice may look like. This is me and my colleague, Daniela Brown. We run our trauma-informed care program here for federally qualified health centers in Texas. And so just to give you a little snippet of what a federally qualified health center is we're really a safety net for those who are underinsured. Maybe they have no insurance. But we really provide high quality comprehensive care in behavioral health, medical, dental, and substance use areas. And so our health centers are in urban, rural, and frontier areas of Texas. And really our mission is advancing healthcare across for all Texans. We have 73 health centers, over 650 sites, and serve close to 2 million patients a year. So today I just thought we'd really just kind of try to understand what trauma is and its impact on individuals. Hopefully at the end you can recall some key components of the trauma-informed care, such as language recommendations and looking at those pillars. We want to reflect on ways that TACHC can be applied to your current dental services. And then we want to know how to collaborate with colleagues and patients really to prioritize trauma-informed care. Because we are talking about trauma, sometimes you may hear material that could be difficult to hear or to view. Please take a break whenever you need to. Get up, walk around, take a drink, whatever you need to do to support yourself. So let's get started. So what is trauma? Trauma is a word that has really made its way into a lot of journals and blog posts and even mainstream media. Trauma is really becoming this common knowledge. As a society, we're beginning to understand the effects of trauma and how it affects individuals. Trauma happens when any experience stuns us or it overwhelms us. We may feel helpless or like we've had our feet knocked out from underneath us. Trauma happens in an event or maybe a series of events or maybe even just a set of circumstances. And these events can be experienced or witnessed by an individual. And there's typically this fear of that they may be harmed physically or emotionally, or maybe even lose their life. And these events have lasting adverse effects on individuals, on their mental, physical, social, emotional, and spiritual well-being. Traumatic events can be family and social violence, assaults, wars, disaster, and even predatory violence that really confronts people with such shock that it may temporarily or permanently alter the way that we are able to cope. And so experiencing trauma really may even affect our natural biologic threat perception, which we're going to talk a little bit about, and even change the way that we see ourselves. And so back in the 1990s, late 90s, a weight loss clinic in San Diego, California, made a really profound discovery. Dr. Vincent Folletti, who was a medical provider at Kaiser Permanente, he was approached to start a weight loss clinic. And he agreed. He had instant success with individuals losing 1, 2, 300 pounds. But when he started having those that were most successful drop out of his program, he began to ask some questions. The first thing that he discovered, though, was that many of the people who were successful at losing weight began to fall away. He met with them, did some investigation of over like 286 individuals. And what he discovered that childhood abuse was remarkably common in every one of those patients. And if it was present, always seemed to be the springboard to that onset of obesity. So for many, obesity really wasn't their problem. It was really their protective solution to keep them safe. So this, he presented this information at a conference, was kind of laughed off the stage, but Dr. Robert Onda from the CDC was there, and he said, if what you're saying is true, we really need to do some research into this. And so the Childhood Adversity Study, or the ACEs study, and subsequent research really has found powerful connections that include both physical and mental health outcomes, including the development of chronic disease and major causes of adult mortality in the US. There's a link to alcohol and drug abuse, the diminishment of lifetime opportunities regarding education, occupation, and income. There were 10 types of childhood trauma that they measured in the original study. There were 5 that were experienced directly by an individual, and then 5 that were related to a family member. And each type of trauma counted as 1. So an individual could have an ACE score between 0 and 10. And the important thing to remember was that the research consistently has found that the higher your ACE score, the higher likelihood at least one negative outcome. And the type of trauma did not factor into that score. And so trauma is more than an event, though. It's really what's happening in our nervous system. When the primitive parts of our brain really perceive danger, they automatically activate this extraordinary amount of energy. We begin to have stress hormones that dump out that cortisol that you hear people talk about, and it's released and it sparks off this fight, flight, freeze, or fawn response. That response is totally normal. It's what keeps us safe. It really is there to ensure that all those non-essential tasks that are going on within our body are slowed down, and that we're prepared to fight or flight for whatever it is that we need. So what does this look like? So your body's going to have this reduction in blood flow away from our vital organs and into our muscles so we can be ready to run. Or our breathing becomes fast and shallow. The production of saliva begins to decrease, and our pupils really dilate so they can take in all the information of everything that's happening around us. And something important to note when this happens is that our verbal ability also decreases. So if an individual has experienced trauma, it can be very easy to re-traumatize them if providing services, we're not aware that these things could be happening. So stress also is a very important part of this conversation. We often think about stress as something that we don't want, right? But or something we want to avoid. But while that can sometimes be true, stress really at its core is how our bodies react to demands or stressors. And so we talk about 3 types of stress. We have positive stress, tolerable stress, and toxic stress. Positive stress is also called eustress. It's very moderate. It usually motivates us to do something, gives us a lot of energy in the short term, and we regard this positive stress. And so it usually happens, and we have coping abilities to handle that type of stress. And then that tolerable stress. So this can develop after exposure to one or more traumatic events or that set of circumstances. So say you were on a hike, you ran into a bear in the woods, that would be pretty stressful. And so your body would jump to pumping out those hormones, and you'd shift into that fight, flight, freeze, or fawn response to protect yourself. So maybe our bodies shift into fight and we're trying to fight the bear off, or we shift into flight and we're going to run away from the bear. Or maybe we froze and we're playing dead. Or maybe we're trying to give them part of our sandwich or something to appease them to get them away from us. These stress symptoms develop quickly, but they don't usually last long, and they're really mitigated by those positive relationships. So people around us who love us and support us and help us work through those events. But then there's toxic stress. And this is that excessive or prolonged activation of our stress response, that flight, fight, freeze, or fawn. And so if you go back to that bear, you're thinking about, or really any traumatic event or stressor that you have, what if that bear stuck around? Or you had to see the bear every day? Or the bear really hurt you? Then that would become toxic stress, and your body might be activated all the time so that things that even remind us of the bear cause our bodies to react. We're dumping that cortisol, we're moving into fight, flight, freeze, or fawn. So toxic stress is where we begin to see damage in our learning, in our behavior, and in our health across the lifespan. It's also where we might see that development of those unhealthy or maladaptive coping skills. So what could it look like? So for those whose response is fight, you could see this play out like rage, confrontation. Maybe it's really high energy. If it's flight, you want to run away from the threat. And so this really could look like maybe panic. So if you think about people laying in a dental chair, you may see a lot of panic or anxiety. That person's response is a flight response. And so when our bodies perceive that fighting or running away really isn't an option, then we're programmed to freeze or to go limp. And so freeze could look like shutting down, maybe dissociation or really low energy. And then lastly, we have fawn. And this is where, again, we're trying to appease a threat. And this could really look like people pleasing, maybe some codependency or lack of boundaries. So unfortunately, ACEs are very prevalent. Our current data from the CDC really shows about 61% of adults report that they've had experienced at least one type of ACE, and nearly 1 in 6 report that they've experienced 4 or more. So ACEs affect all communities. And so while that original study really was from a population that was mostly white, middle class, employed, college educated, and they all had private insurance, subsequent studies have found higher prevalence rates of ACEs in people experiencing poverty, people from racial and ethnic minority groups. So I really want us to look at this image and kind of go down to that bottom part, those last 2 pieces where it says generational embodiment or historical trauma, and then the next one up, that social conditions or local context. We know that trauma can be passed on, and historical trauma impacts populations who really have experienced collective, long-term, and widespread adversity over generations. And this can look like slavery or segregation, racism, violent colonization, and genocide. And these really contribute to that next step up in that pyramid, which refers to the social environment. And these can be chronic and look like community violence, maybe structural oppression and racism. And these are structural, and they're institutionalized systems that really affect the well-being of individuals living within them. So ACEs are strongly correlated in a dose-response fashion with some of the most common and serious health conditions facing our society today. So there's finally evidence that what happened to you in childhood really could have this huge impact on your quality of life and your health outcomes, even more than what we thought before. And so in that long term, survivors who may really engage in behaviors that help them cope with traumatic memories, but that may really have negative health outcomes. And so, for example, somebody who has experienced trauma may smoke cigarettes. They may drink alcohol or overeat to manage those emotions. And so although these behaviors really help them in the short term, what we see is those long-term effects, and especially even in oral health care. And so just as that original ACE study found that correlation between that exposure to adversity and poor health and social outcomes, other studies have now found similar correlation with oral health outcomes. And so one study found that those who had an ACE score of 4 or higher were less likely to receive adequate dental care as a child. Another study found that children who reported ACEs were more likely to have poor oral health and significant tooth decay, a higher incidence of gum disease, and fungal or viral infections of the mouth. So additionally, having these multiple experiences of childhood adversity really has this cumulative effect on oral health, meaning those who had more adversity tend to have poorer dental health and more individual caries. So what could this look like in your dental practice? So you may recognize from this list, you may see some patients in here, some of those patients who have frequently missed appointments. Maybe they wait till they need to have a tooth pulled versus coming in earlier and really working on that tooth. Maybe they have trouble adhering to treatment. But what about our staff? Sometimes these are things that we might see in our staff who've experienced trauma and are having a lot of stress at work as well. So what does this mean for us? What this means is that we really have to begin to have real conversations about trauma. So we use these 4 R's with our health centers. We have to realize that trauma is real and that it's pervasive, and everyone has been affected, whether it's them or somebody that they know. No one's immune to the traumatic effects. We have to, as providers and staff, we have to begin to recognize what those signs and symptoms of trauma are. We have to learn to respond to individuals and their families who've experienced trauma. And then lastly, we want to resist or minimize re-traumatization when we look at our policies, practices, and procedures. Trauma-informed care really calls for this shift, and it really requires this team-based approach that includes training all of your organization, their leadership, their board members, all of your staff. And to begin to do that, these 7 pillars here are something that we teach our health centers to really begin to ground their work in. And they are transferable to all departments, really to propel this integration across disciplines where we're seeing safety. So throughout our health center, staff and people that they serve feel physically and psychologically and morally and spiritually and culturally safe when they're with us. So trauma-informed care really is this approach that grew out of an awareness that sometimes traditional approaches just don't work, and that many people have experienced adverse events or traumatic experiences. And they typically come to us. We see people within our organization when they're really at their most vulnerable, people who need help, and they might be feeling unsafe or disempowered. And so trauma-informed care really recognizes that pervasiveness and the impact of adversity. And so in the dental setting, this can really indeed be challenging for some individuals due to their past traumatic experiences, or maybe even a fear of dental procedures. And so it's a real and valid concern. You know, the sounds, the smells, the sensations of being in a dental office can really begin to trigger this anxiety or distress. And it's essential for our dental professionals to be aware of this and to work with patients to really create a comfortable and supportive environment. And so what can we do? So here's a few TIC strategies really to consider. Just meeting with a patient maybe prior to appointment or where the procedure is going to take place, and let them know everything up front of what's going to happen. We can offer calming and soothing office environments. So maybe this is avoiding stressful TV that's on in the waiting room, or maybe you can let them listen to music. They can just stick in their earphones and have something that they are distracted by a little bit. We want to give as much control and choice as possible. So being flexible about who's in the room with them. Maybe they're negotiating the angle of the chair. Maybe even we've seen this, people starting to let them use the x-ray protector over a patient to kind of have that pressure on their body to help them relax during an appointment. And then we want to validate their concerns and express empathy. So this is all about creating that partnership and making sure that the patient feels heard and understood and really involved in their own care. And then we want to apply universal trauma precautions. This means that everybody that we come in contact with, we will assume that they may have had a traumatic experience. And so we really want to go back to those 7 pillars and look at safety for them. We want to build trust. We want to build collaboration in with them. We want to give them choice when they can have choice. We want to empower them. And then for the providers, really I love this pyramid. We use it often. At the very bottom of this pyramid, you can see patient-centered communication. And this is really specific communication and behavioral techniques that can help manage patients' anxiety and really increase rapport with trauma survivors. Providers really need to tune in and not just to the symptoms, but also to the emotion and the concern that the patients are bringing. And then we see understanding health effects of trauma. So this next level of the pyramid really consists of being aware of and understanding the effects of trauma. And this does not require individuals to delve into trauma histories. It just simply means that there's some education about health-related effects of traumatic events. We know trauma really can disrupt daily routines, and including oral hygiene practices, right? So those who are dealing with emotional aftermath may not be brushing every day, maybe not flossing, which really we know contributes to some dental issues. And then the next one there is collaboration and understanding the professional role. So this really is looking at how you're collaborating with other professionals and through the understanding of your own professional role. We can see dentists collaborate with other healthcare professionals like emergency room physicians, oral surgeons, maybe even trauma specialists. And this collaboration really ensures a comprehensive approach to patient care. And the next one's getting a little bit harder, but we're really looking to understand our own history of trauma. And so when we begin to understand our own history of trauma, when staff themselves may be actually survivors of traumatic events, and everybody may feel uncomfortable talking about trauma for fear of reactivating maybe their own feelings or their own emotions that they've went through. So it's important for providers to really learn some empathetic communication skills. Learning those skills really can help you avoid reactivating your own memories of trauma. And then screening. We don't recommend that all patients and staff be screened for trauma. Most dental care settings do not offer providers the time or resources to really conduct or discuss the results of a screening. So again, we encourage you to use those universal trauma precautions and assume that everyone will, again, that we come in contact with may have experienced trauma. And then lastly, to wrap things up here, just thinking about patient-centered language recommendations. Instead of saying patient, maybe we move to individual or member or person. Maybe instead of saying male or female or using gendered pronouns, we use people or they, them, their. We use their name instead of using a pronoun. So just thinking about ways that we could change our language is a very beginning step to becoming trauma informed. And I'll pass it back to Dawn.
Thank you, Amy, for that amazing presentation. It was very insightful and very informative. I really appreciate you taking your time to join us today. Thank you, everyone, for listening to her presentation. And at the end of our entire session, we will have a Q&A, so all participants will get a chance to ask any questions if they have them, or if you have some burning questions you need answered right now, please put that in our Q&A box or in the chat. So let's turn our attention to our next presenter. Our next presenter is Jerico Cummings, and then let me get my slide up here for him. right, thank you. So our next presenter is Jerico Cummings. They are a member of the Cheyenne River Sioux Tribe and Two-Spirit LGBTQ plus training and community engagement specialist for the past remembered project at the North Portland Area Indian Health Board. Jerico studied sociology and Native American studies at Montana State University, where they were involved in diversity, equity, and inclusion efforts across campus. Personally and professionally, Jerico feels called to support community at the intersection of indigeneity, sexual orientation, and gender identity. They currently work at the North Portland Indian Health Board and as a training community engagement specialist. And I will turn our screens over to Jerico, to our next presenter. And thank you again, Jerico, for presenting today. So let's turn our attention to Jerico. Thank you.
Sorry, navigating a few screens here. Hello, everyone. I am going to give somewhat of a little crash course on creating 2S LGBTQ plus affirming spaces, and hope to tailor it a bit to dental health and oral health care as it pertains to y'all's profession. I also want to give a little bit of a disclosure as well that I will talk a little bit about various mental health struggles around depression and suicidality, experiences with discrimination as well, and just want to give that preface here before going farther. A little bit about the PAS Remembered project. Our work centers the Two-Spirit and LGBTQ plus community, and specifically the strengths, resiliencies, and histories in our movement toward health equity. And we do this through community engagement, research, and advocacy, where we work toward a liberated 2S LGBTQ plus future. It includes the memories of our Two-Spirit ancestors, the wisdom of our elders, and the creativity of our young people. I guess maybe before going into the content a little bit more, I just also want to preface with acknowledging the fact that Indian Health Service, tribal, and even urban facilities don't have super affirming intake processes as it pertains to our Two-Spirit and LGBTQ plus community members, where chosen names are able to be collected, or their gender identity. And so I kind of want to have a bit of a shared understanding of what some of these terms mean as it pertains to gender and sexual orientation, so that y'all are able to affirm individuals in their gender identity when they're coming in to seek dental health and oral health care in your professions. And so gender is one that I feel like is a great starting point. It refers to a person's internal sense of identity and has ties to their social world. This is often like a way that, or I guess presentation, physical presentation is a way that someone may showcase themselves and their gender identity to the world. And also want to just acknowledge here that someone may identify as a man, a woman, both, neither, or an entire identity in and of itself. And we often, it's a best practice not to assume one's gender identity until they disclose this to us. So as it pertains to maybe a provider and client interaction, or as services are being offered, definitely let the individual disclose their gender identity to you. And as Aimee mentioned previously, the use of pronouns becomes important here as well. We don't want to assume an individual's pronouns and get it wrong and then perpetuate trauma, for example, as providing services. Just some gender terms that we use in the field: cisgender, so someone who is cisgender, their gender identity corresponds with their sex assigned at birth. Transgender is getting at someone whose gender identity does not match their sex assigned at birth. and a non-binary person's gender identity does not evenly correspond with the male-female binary. Sexual orientation, just some more common ones that might be familiar, like gay, lesbian, bisexual, queer, or some that we hear of most often. But these refer to the way one would describe their emotional, romantic, or sexual attraction. And I guess ultimately, similarly to gender here, like we don't know what someone's sexual orientation is unless they disclose this to us. And so just sharing a little bit more about like my own personal experience and like dental visits and things of that nature. I remember within the past several years, a provider was trying to make small talk with me, and he ended up commenting on my hair and saying I had very beautiful hair and things of that nature, and unfortunately made this comment that assumed that I was straight, and unfortunately shared like that he would not allow me to date his daughters because of how beautiful my hair is, that I had much more beautiful hair than his daughters, which is a very wild compliment and things to say, and ultimately just wanting to share here that that assumption of my sexual orientation like made me kind of shut down and not really want to further engage in small talk. And so want y'all to maybe be privy to the things that you say and kind of the topics that you bring up as you're trying to maybe decrease the stress levels of the interaction, and in the name of providing services and affirming services as well. Oops. See. So Two-Spirit, that's designated as the 2S in our 2S LGBTQ+ acronym. This is getting at or referring to an Indigenous person who expresses their gender identity, spiritual identity, or social role in a traditional or non-Western way. And this term came about in the early 1990s and is based on Anishinaabe conceptualizations of gender diverse roles. What's really cool is that hundreds and even thousands of other conceptualizations have existed across time and space, and many are still being used today. One term that comes up more in circles involving youth is indigiqueer, and this term is specifically getting at Indigenous, American Indian, Alaska Native individuals that might identify as lesbian, gay, bisexual, but do not identify as Two-Spirit. And so here are some statistics or data points that our project collected a few years ago in the Pride and Connectedness Survey. I won't go too in depth over the data points more specifically, and just want to acknowledge that members of the 2S LGBTQ+ community do experience discrimination, and with some of the interviews that we conducted found that individuals hearing messaging about their trans identity not being normal or being bullied or harassed because of their 2S LGBTQ+ identity does occur, and it occurs in Native and non-Native spaces. And these are experiences that individuals are showing up to clinics and things of that nature with. And so keeping Aimee's talking points in mind here, like we ultimately don't know what lived experiences and realities folks have experienced before they get into the chair or the check-in desk or even the lobby, and to be mindful of creating welcoming and not super like stressful, fast-paced kind of environments where folks feel their nervous system heightened and that they're on guard and things of that nature. And again, won't go into these data points super in depth, and this might be a little bit more medical and behavioral health focused, but also just want to share that individuals did report experiencing suicidality in their lives, as well as feeling depressed during a period of time around the time that the survey was conducted. And so these are additional things that patients are bringing into these interactions and into the clinics, and again, keeping some of those trauma-informed care pieces that Aimee shared in mind. And then again, we also want to mitigate stress and trauma in various social contexts and dental settings here more specifically. And one thing that's been shared with me and that I've heard within community is that it's very difficult to get folks into the door in general, specifically in the realm of like preventative care visits. And so one bad experience can easily turn someone off and keep them from coming back. And so while these experiences with discrimination and mental health issues and challenges more broadly, keeping in mind that we don't want to further exacerbate those and like misgender someone or assume their sexual orientation or even other parts of their identity, and ultimately have them feel like the clinic or you as a provider aren't a safe space for them to continue seeking out services in a place that they ultimately won't want to come back to when they have to get serious dental work done, for example. And I'd like to share here too as just like a quick, simple data supported tip and tool is that one study found that the use of correct name and pronouns was associated with a 56% decrease in suicide attempts. And so everyone I know that is working in the public health sphere and ultimately providing services wants to see this percentage drop down to 0. And ultimately what this slide tells us is that in the meantime, the least we can do is use individuals' correct name and pronouns, and that it can be life-saving. So if like your intake processes, for example, don't account for inputting chosen name or pronouns, it's always totally fine and even encouraged to ask folks these questions. So you could start out by saying like, hello, my name is Jericho. I use they, them pronouns, and I'll be doing your cleaning today. Can you tell me what name you would like to go by in this interaction and what pronouns you would like me to use to refer to you? And also want to share here that there's one clinic that we worked with that their intake processes did not have the option to populate these fields. And so there are creative ways to capture this information. And so with this specific clinic, they had a whiteboard in the exam room, and they would write down the individual's chosen name and their pronouns after asking for those from the patient. And so just in your setting and in your profession, whatever feels like an appropriate solution, I totally encourage, like, lean into that, try out different ones, and ultimately see what works best for you. And ultimately the patient too. And again, here highlighting the importance of affirmation. So there was a study that found trans youth who have socially transitioned have levels of anxiety and depression comparable to their cisgender peers. And so this social transition, getting at the use of a different name that's what's on their birth certificate, for example, or pronouns, like various different pronouns are just a few examples. Dress is another one. And so ultimately affirming trans and gender diverse youth and individuals more broadly can help close the gaps that we see as it pertains to mental health issues specifically. I also want to share here too that we're all on various different journeys and like entry points on as like we're learning to affirm Two-Spirit and LGBTQ+ folks. We're bound to make mistakes at some point, and that's okay. The ask and the guidance here is if you slip up or make a mistake, simply apologize, move on, and try your hardest to get it right the next time. And as Aimee covered near the end of her her presentation and her slides, we want to be aware of our use of language, and more specifically aware of gendered language and the assumptions that we express through the use of language. And so one thing I like to do is just opt for gender neutral language and terminology whenever possible. And if someone discloses that like gender neutral terminology is not appropriate or applicable to them, that they would feel more comfortable with she, her, he, him pronouns, definitely make that switch. But just some examples I like to use are y'all, or friend, relative, and Aimee gave some other examples too, like utilizing patient when you might not know what their pronouns are if you forget to ask, and things like that. And another thing to be mindful about with the use of pronouns is that they may change based on who is asking, when and in what context the question is being asked, and also who might be present. And it's good to ask regularly for patients' pronouns, even if they've shared them with you in a previous visit. They can change across time and space. And so want to be mindful of that. And especially when working with youth and young people, they may request you to use different pronouns when their parents are present. So back in like the operatory area where it might just be you and a youngster, they may ask you to use gender neutral pronouns, for example, but when you have to go out and talk with their parent about like aftercare and just like updates on their teeth and what's going on in their mouth, they may want you to use the pronouns that align with the gender on their birth certificate. So having to be mindful of that switch based on who's present. And lastly, I just want to share here too, like we're not asking you to abandon your individually and personally held beliefs. It is our belief that as service providers, affirming individuals and their gender, sexual orientations, and other key identities has less to do with what one person believes individually. And what's most important is providing quality care and reducing harm in the process. So keep that in mind. And then happy to shed light on these resources a little bit more, but feel free to check out the PAUSRemember.org website. We have a bunch of different resources for providers, community members, and things of that nature. And so a few of them that might be specific as it like pertains to intake processes and healthcare more specifically is our trans and gender affirming care strategic vision and action plan. There's a bunch of resources in the appendix of this. We have a clinician consult warm line. So if you're struggling to or wanting advice on how to be more affirming in your practice as it pertains to meeting the needs of a Two-Spirit or LGBTQ plus American Indian Alaska Native patient, this is a like wonderful one-on-one resource to get your questions answered. In addition to this trans and gender affirming care echo, which is a community of practice of practitioners across all disciplines, where kind of navigate patient cases, didactics are shared and things of that nature. So this one is much more communal than the consult warm line that's a little bit more individual. And we have this wonderful Celebrating Our Magic toolkit that has resources for American Indian, Alaska Native, transgender, Two-Spirit youth, their relatives, families, as well as their healthcare providers. And there's a bunch of really cool like guides in here on the use of pronouns, why asking about sexual orientation matters. And we have some really cool affirming clinical posters. I will shed light that none of them focus on dental care specifically, but if you and your clinic or your community want to have affirming to us LGBTQ plus dental focused posters, I strongly encourage y'all to find like maybe local actors or individuals that would be down to be in a photo shoot to help make this space feel more affirming to Two-Spirit and LGBTQ plus folks navigating care and accessing services. And with that, I will turn it back over to you, Dawn.
Thank you so much, Jerico, for that information. I really appreciate all the slides and the just amazing things that you shared with us today. And I really hope this brings further optimal care for all of our patients when we take care of them in any kind of setting, regardless if it's dental, mental health, or just a general clinician settings. We really want to focus and make sure that our tribal people are taken care of in any way possible. So I really appreciate you, Jericho, for your presentation, and thank you for your time, for you and Aimee to take your time today. I am now opening this session for questions. If anyone has any questions for either one of our panelists today, please ask them in the chat or put them in a Q&A box. I will give like a few seconds for anyone to put some questions in there. I do have a question that did came up. Somebody had asked, what would you do? And this would probably go more like for Aimee. If an individual was experiencing some kind of trauma or self-harm, how do you think we should address the patient if it's in a setting where it's not private? A lot of our clinics, facilities don't have private walls. Some of the operatories are very open, or even the walls are very thin. How do you think, we can address a patient that may be showing signs of trauma or self-harm, and how would we talk to them about getting them help?
Yeah, that's hard, especially if there's not a safe place, right, for you to move that patient to somewhere where they would have privacy. But I still think making that safe environment where they know that they're safe there, maybe even doing some coping skills with them, right, in the immediate, whether it's, just 5, 4, 3, 2, 1, like name 5 things that you can see, 4 things that you can hear, moving through a coping skill like that to ground them to the here and now, where you can have that conversation with them. And then obviously not letting them leave your facility, especially if they have a plan. Until you know that they have a safety plan in place. Maybe that's calling a local mental health authority that would help you work through that specific suicidality if they have that plan. Jericho, I'll definitely defer to you too to answer that.
I think is outside of my scope of expertise, unfortunately.
Thank you, Aimee, for that. Does anyone else have any other questions or anything they'd like to add or comment on today's session? We greatly appreciate any kind of comments you may have too as well. Maybe mention where you're from, and also mention anything that you might have for today's session.
John, I'm going to put my email in the chat too, because I know it was a lot of information that we just went over. So it might take you time to process both of these pieces. And so if you have questions, anybody has questions after the fact too, you can definitely reach out.
Yes, please share that. Definitely, if anyone else has needs, would like to ask Aimee any other questions, she will put her email in the chat. And Jericho also put their email in the chat. Sorry about that. Their email in the chat as well. And that way, if you have any questions, you can address them there. We really appreciate everyone, again, taking their time. Do we have any other comments or anything that we like to add on for today? Okay, well, I will go ahead and stop recording here.